Welcome to this explainer. Today, we are breaking down the vital RCOG Green-top Guideline No. 21. If you're an MRCOG candidate or a practitioner looking for a really structured, high-yield mastery of ectopic pregnancy diagnosis and management, you are in exactly the right place. We're going to transform those dense clinical guidelines into clear, actionable knowledge that you can immediately use in your exams and, more importantly, right there on the ward. All right, let's just dive straight into our agenda for this clinical pathway. First, diagnosing tubal pregnancies. Second, managing tubal pregnancies. Third, atypical ectopic pregnancies. And finally, anti-D and future fertility.
Now, just so we're all on the same page, everything we're covering today comes directly from the RCOG and APU Joint Guideline No. 21. This document officially replaced the older 2004 edition and essentially wrote the modern standard of care. Our goal here is to distill this massive document into the visual, easy-to-retain format you need to completely excel.
Okay, Section 1. Diagnosing tubal pregnancies.
Picture this, because it's a classic exam scenario, and honestly, a super common real-world dilemma. You've got a stable patient, and her serum β-hCG comes back at 800. Because that number is relatively low, does that mean an ectopic pregnancy is safely off your differential diagnosis? Take just a second to lock in your answer. The answer? An absolute firm no. And this brilliantly illustrates a grade B recommendation from the guideline. You literally cannot use a single β-hCG value in isolation to predict an ectopic pregnancy. It is a really dangerous clinical misconception to assume that a low level, like less than 1,000, just rules out an ectopic. In reality, plenty of ectopic pregnancies present with values way below that threshold.
So, what do you rely on? Well, your absolute gold standard here, which is another grade B recommendation, is the transvaginal ultrasound. When you're performing this, you've got to actively look for a separate adnexal mass that moves independently of the ovary. In about 50 to 60% of cases, this is going to look like an inhomogeneous or non-cystic mass. But here's the catch. You have to be extremely careful not to confuse a pseudosac, which is really just a collection of fluid in the endometrial cavity, with an early intrauterine pregnancy. Oh, and one more thing. Serum progesterone is not useful for predicting ectopic pregnancy. Make sure you remember that grade B recommendation for sure.
Moving right along to Section 2, managing these tubal pregnancies. All right, let's talk surgery, because knowing exactly when to use which procedure is heavily tested. A salpingectomy is your grade B preference if the patient has a completely healthy contralateral tube. You just remove the affected tube entirely. But a salpingotomy, where the tube is carefully opened and the pregnancy removed, is a grade C recommendation. You reserve this for patients who have a history of fertility-reducing factors, things like previous tubal damage or pelvic inflammatory disease. Now, if you do go the salpingotomy route, you absolutely have to counsel the patient on the risk of persistent trophoblast and the need for rigorous β-hCG follow-up. Now, what if you're leaning toward expectant management instead of surgery? Well, your magic number here is less than 1,500. Expectant management is a fantastic, highly viable option, but only for clinically stable women who present with a decreasing β-hCG that starts off below this 1,500 international units per liter mark. And that brings us to the pharmacological route. The Methotrexate protocol is strict, guys. Systemic methotrexate is given as a single intramuscular dose of 50 milligrams per meter squared. But the vital timeline you need to memorize is measuring serum β-hCG specifically on day 4 and day 7. You are looking for a greater than 15% drop between those two specific days. If it drops like it's supposed to, great, you check weekly. If it doesn't, you're going to need to rescan and potentially administer a second dose.
Next up, Section 3, atypical ectopic pregnancies.
Okay, how do we actually tell a true cervical ectopic apart from a miscarriage that just happens to be passing through the cervix? This is a massive clinical pitfall. Your criteria include an empty uterine cavity and a barrel-shaped cervix with the sac sitting below the internal os. But the real diagnostic game changer here is the absence of the sliding sign. See, when you apply pressure with the ultrasound probe, a miscarriage will just slide right against the endocervical canal. A true cervical ectopic, because it's implanted into the tissue, absolutely will not slide. Moving higher up the reproductive tract, the guidelines draw a really strict line between interstitial and corneal pregnancies, which honestly get confused all the time. Interstitial pregnancies happen in the intramural part of the tube.
On a scan, you're going to see less than 5 millimeters of surrounding myometrium and this highly specific interstitial line sign. Corneal pregnancies, on the other hand, are strictly defined by implantation in a congenitally abnormal unicornuate uterus. Here, the sac is mobile, it's separate from the main uterus, and it's attached by a vascular pedicle.
Let's strip away the clutter for a second. This matrix right here is your high-yield triage cheat sheet for atypical cases. For cervical pregnancies, medical management with Methotrexate is preferred. We want to avoid life-threatening hemorrhage from surgical attempts at all costs. Conversely, current literature totally supports a surgical approach for Caesarean scar pregnancies. Interstitial? Well, that can go either way. But corneal and abdominal ectopic pregnancies definitively 100% require a surgical approach. Knowing this breakdown inside and out is absolute gold for your exams.
Finally, Section 4, Anti-D and Future Fertility. So, once the immediate crisis is resolved, you've got to check the patient's blood group. The grade D recommendation here is that you must provide anti-D prophylaxis to all RhD negative women who have either undergone surgical removal of an ectopic pregnancy or who are experiencing repeated heavy bleeding associated with abdominal pain.
Naturally, one of the very first things a patient is going to ask you is, am I going to be able to have a baby in the future? When you're counseling them on long-term prospects, your advice has to be tailored entirely to their history. If they have zero history of subfertility, you can confidently reassure them that there is no difference in future fertility rates, whether they had expectant, medical, or surgical management. However, if they do have a pre-existing history of subfertility, expectant or medical management actually provides significantly better reproductive outcomes than radical surgery. And a quick but super important note here, if you went with pharmacological management, there is a strict waiting period. Any patient receiving systemic methotrexate has to be clearly advised to wait at least 3 months before trying to conceive again. This is purely because the drug lingers in the organs and has the potential to affect early fetal development in a subsequent pregnancy. But listen, beyond all the rigid protocols, the thresholds, and the surgical techniques, we have to remember the human being on the other side of that ultrasound probe. The guidelines explicitly call this out. Nearly half of the women experiencing an ectopic pregnancy are going to suffer a significant grief reaction. They need deep empathy, crystal clear communication about their options, and direct referrals to support networks, like the Ectopic Pregnancy Trust or local bereavement counseling. Which leaves us with a final thought to really chew on today. As you master these beta-hCG thresholds and surgical pathways for your MRCOG, how will you ensure you're providing true, empathetic, patient-centered care in the middle of a stressful clinical emergency? Because understanding the guidelines is only half the job. Supporting your patient through profound loss is the rest of it. Thank you so much for joining me for this explainer on Guideline 21. I really hope this structured approach helps you achieve total mastery. Keep studying and take care of yourselves out there.